Welcome to our webinar tonight, put on by the AO Trauma North America Hand Education Committee. Tonight's topic is on perilunate dislocations of the wrist. My name is Kevin Malone. I'm your moderator for this evening. I'm in Cleveland, Ohio, and I am joined tonight by Jay Bridgman from the University of Missouri and Jeff Lawton from the University of Michigan. These are the disclosures for our faculty, which we have investigated and determined that there will be no conflict of interest with any of the material presented tonight. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. AO North America does not endorse nor promote the use of any specific product or service of commercial entities. And this last statement isn't all that appropriate because we're not using any equipment in this course, but there will be different implants shown in case presentation here tonight, but we don't endorse any specific implant company or manufacturer. As is typical with all of our webinars on Zoom, all of your microphones have been muted and your video cameras have been turned off. You will have the opportunity, and we actually welcome participation. And so please use the Q&A box as you, if you have any questions that are develop or arise during our session tonight. And we as faculty will do our best to answer them, some direct response to you, but other questions we may save to pose for more open discussion. And the chat box, please don't use that. That's really for our faculty and AO staff helping coordinate tonight's event. So again, we're going to be talking about perilunate fracture dislocations, which are a spectrum of bony and ligamentous injuries to the wrist that typically result from high energy mechanisms of injury. Fortunately, they are relatively uncommon, but they can present challenges both in diagnosis and management. Careful interpretation of injury films, adherence to established surgical principles, and close follow-up of these injuries can often restore functional motion and strength to the injured wrist, but these injuries can also result in long-term consequences for the patient even when the correct diagnosis and treatment has been rendered. So our objectives for tonight will be that at the end of this session, you will be able to interpret radiographs to correctly diagnose these injuries, and then to create an appropriate surgical and rehabilitation plan. You'll be able to recognize the signs and symptoms of median nerve dysfunction that can commonly occur with these injuries, and have an understanding as to how to address those issues. And then also you'll be able to manage patients with late presenting and or missed perilunate injuries, as well as those who develop morbidity and dysfunction as a result of injuries that were either presented late or even those that are treated appropriately acutely. This is our agenda for tonight. And if we have some time, we'll go over some cases, particularly with our last session. But again, please post your questions on the Q&A section of the Zoom so that we can make sure that all of your needs are met. So thank you. And I'm going to start with the first session, and we're going to talk about mechanism of injury and initial evaluation of those patients who present with perilunate injuries. So perilunate dislocations are, as mentioned, the result of high energy mechanism and a spectrum of ligamentous and bony damage. They are often underdiagnosed. They can be challenging to treat. Historical outcomes are not great with regards to range of motion, but good functional recovery can occur and is expected to occur in most situations. Prompt reduction with ligamentous and bony repair can achieve favorable results. So perilunate instability is a dissociation of the lunate from the carpus, and this can include perilunate and lunate dislocations, as well as fracture dislocations that we will discuss this evening. This results oftentimes in a disruption of both intrinsic carpal and extrinsic radiocarpal wrist ligaments. And despite the magnitude of the injury, the X-ray findings can often be subtle, and up to 25% of these injuries are missed on initial presentation, even with radiographs reviewed by emergency department staff and or radiology staff because of the subtlety of some of these findings. Mayfield described a sequence of perilunate dislocation, and we're going to talk about all of these in a little bit more detail. Stage 1 is scapholunate dissociation, which we see perhaps significantly more frequently than the later stages. Stage 2 is a capitolunate dislocation. Stage 3 is a lunotriquetral dislocation, and at this point, the carpus separates from the lunate. Stage 4 is then a lunate dislocation from the radial fossa into the carpal tunnel, and it is still oftentimes attached to the radius by the short radiolunate ligament. And so to outline this Mayfield sequence here with this lateral projection of an X-ray, you can see the radius at the bottom, the lunate with the scaphoid behind it, and the capitate up top, as identified here. With normal wrist extension, you can see, the angulation through the radiolunate joint and perhaps a slight translation and angulation at the lunocapitate joint. At stage 1, you have scapholunate dissociation, and so now you have hypermobility of the scaphoid relative to the lunate. Stage 2 as a capitate dislocation relative to the lunate. Stage 3 is now your perilunate dislocation, and as it progresses further, stage 4, the lunate is directed volarly into the carpal tunnel. So again, scapholunate dissociation in stage 1 can be identified on plain film X-rays and with some physical examination findings, including the scaphoid shift test, which is performed on a patient with their wrist ulnarly deviated. You place your thumb on the scaphoid tubercle to block the scaphoid from going into flexion, and then bring the wrist into a radial deviation. And if there is a painful clunk appreciated, it is the dorsal subluxation of the proximal pole of the scaphoid over the dorsal rim of the scaphoid facet. And it's important to compare this to the contralateral side because there can be asymptomatic and normal clunks in some patients, particularly with ligamentous laxity. So here is an X-ray of a scaphoid shift. You can see the scaphoid lunate diastasis on the PA view, on the lateral view with the wrist and ulnar deviation. And now with my thumb over the scaphoid again to block it from going into flexion and radial deviation, you can see the proximal pole of the scaphoid sitting dorsal to the dorsal rim of the radius, and that is the scaphoid shift test. There are a variety of different patterns of perilunate injuries. They can be lesser arc injuries, which are purely ligamentous disruption, or greater arc injuries, which are going to involve fracture of either the radial styloid, the scaphoid, the capitate, the triquetrum, and the ulnar styloid. The transscaphoid variant is the most frequently encountered. Again, this typically is the result of a higher energy injury than a simple fall from standing. So shown here, a head over the handlebars of a bike. There can be other associated injuries that may distract your attention from the wrist. If the wrist is identified as an injury, it may oftentimes be difficult to see any significant deformity because of the degree of swelling present. But if there's not a lot of swelling with perilunate dislocations, there will be prominent bone dorsally over the wrist from the capitate sitting dorsal to the lunate. And if there is a pure volar lunate dislocation and the lunate lies in the carpal tunnel, there may be fullness there as well. Important to always assess for median nerve function with lunate dislocations. That nerve, or excuse me, the lunate is now taking up extra space underneath the transverse carpal ligament, and median nerve compression can occur. X-rays are the key to diagnosis for these injuries, and you can see a normal wrist on the right and a perilunate wrist on the left. When we look at our normal films, and then we're trying to use our these same principles when looking at our injury films, we want to look for Galula's arcs. So these should be smooth arcs. At the proximal aspect of the proximal row, the distal aspect of the proximal row, and the proximal aspect of the distal row of the carpus, and they should be smooth. And you can see on your image on the left that you do not see the more distal carpal row or carpal arc here. Other findings that you might see to raise your concern for the possibility of a perilunate injury, in addition to the disruption of carpal arcs, are going to be the overlapping of carpal bones, crowded or jumbled carpal bones, a carpus that is overall shorter than you would expect to see, a triangular appearing lunate because of the angular deformity of the lunate, where you're seeing it in a different profile. And then you always want to look for associated carpal fractures, radial styloid fractures, ulnar styloid fractures, and capitate fractures. But it is the lateral X-ray that is the key to diagnosis. And you should be able to identify the scaphoid, lunate, and capitate on these X-rays as shown here, and they should remain stacked upon each other as demonstrated here. But when we look at injuries of lateral X-rays of wrist injuries, we will see the loss of the collinearity between the radius, the lunate, and the capitate. With a perilunate injury, you'll see the capitate displaced dorsally, and with a lunate dislocation, the lunate will dislocate volarly into the carpal tunnel as demonstrated here on the left. So again, on the right, the perilunate dislocation where the head of the capitate is sitting dorsal to the lunate, but the lunate is still sitting in its normal anatomic relationship with the radius. And then on the lunate dislocation, you can see the lunate is rotated 90 degrees and is expressed volar to the radial, the lunate facet of the radius. This is called the spilled teacup sign. Other things to look at here. Now here's a dorsal perilunate dislocation. And you can see again that capitate sitting dorsal to the lunate. In this image, the Galula's arcs actually looks pretty normal, but you can see the scaphoid fracture on your PA image. And on the lateral image, you can clearly see the capitate sitting dorsal to the lunate. So you do need to look at all of the films when you're interpreting and evaluating these patients, and the X-ray findings can be very subtle. Initially, when these are identified, we want to try to reduce the dislocation in the emergency department. And this can be done really up to a couple of days after injury occurs. It is important to do so because it will oftentimes relieve the pain for the patient. It will relieve any pressure or tension, traction on the median nerve. And if you are successful in obtaining reduction, then you can allow definitive management to be delayed, perhaps until when it's more convenient, or for soft tissue swelling to improve before making surgical incisions. This oftentimes requires more than hematoma block and pulling. Getting good muscle relaxation is very important. After a couple of days, it is very challenging to obtain a close reduction, and these patients are more appropriately treated with an open reduction in the operating room. This is a reduction maneuver as described by Dr. Garcia Elias. And you can see here on this dorsal perilunate dislocation, providing some distraction across the wrist joint, a little bit of flexion with the thumb placed on the lunate to prevent converting this into a volar lunate dislocation, and then a little bit of compression or release of the traction. And oftentimes this can successfully reduce, but it can require multiple efforts, multiple attempts. And again, good relaxation is critically important. Median nerve injuries are common. Acute carpal tunnel syndrome has been identified in up to 25% of cases of perilunate injuries. And this can be the result of either a direct contusion, particularly when the lunate is dislocated volarly into the carpal tunnel, or a stretch injury of the median nerve from its dorsal translation of the capitate relative to the lunate. Pressure can also be placed on the ulnar nerve, on the median nerve from hematoma and swelling that occurs after this injury occurs. If the symptoms do not improve or after surgery, after reduction, and they are not progressive, then this may be more likely a contusion injury to the median nerve. However, if they are progressively worsening symptoms, even despite appropriate and acceptable close reduction, you have to have your mind aware of the need for possible emergent carpal tunnel release. And if the patient is going to the operating room for emergent carpal tunnel release, then you can concomitantly treat the ligamentous and bony injuries at the same time, if appropriate, and you have the equipment you need. So in general, these all require surgery. And I know Dr. Bridgman will talk about some of the published data on non-operatively managed perilunate injuries. Ones that are treated emergent are those that are associated with open injuries, those that have progressive median nerve dysfunction despite closed reduction, and those that are unable to obtain closed reduction. But if you can obtain closed reduction and the median nerve symptoms improve or do not worsen, then this can be done in a semi-elective fashion. So in terms of take-home messages, these are relatively infrequent injuries, but they are frequently misdiagnosed, which leads to poor treatment and poor outcomes. Interpretation of plain films are the key to correctly diagnosing and initiating appropriate treatment. And here, Jay and Jeff, I'll ask you, do you routinely order advanced imaging for these studies, or are you making your decisions on plain films?
I like to get advanced imaging, especially a CT scan. So if there are small fracture fragments, or for example, if maybe there are smaller fragments that are on the volar side that I might not be able to reach dorsally, I could clean those out through a volar approach. It helps me understand the pattern of the repairs and for preoperative planning.
No, I think that's a good point. You should be able to make the diagnosis with X-ray, but if you need more information to create an appropriate surgical plan, CT scan can be very helpful there.
I agree. For the lesser arcs, I don't. For the greater arcs, if I want to understand what's going on at the scaphoid, or if it's a transcapitate head, if it helps me to understand for planning for the bony aspect of it.
Thank you. Prompt reduction should be attempted for these patients. Median nerve injuries should be recognized and may play a role in the timing of surgical intervention. So with that, I will stop my presentation and I will turn this over to Dr. Bridgman for his discussion of surgical management of the acute perilunate injury. Jay?
All right, so again, my topic tonight is about the acute surgical management. And we're going to begin with a case. This is a 22-year-old male who was injured in football practice. He plays on a lower tier college football team. Fallen outstretched hand. He had pain, swelling, and deformity. And the reduction was attempted by the athletic training staff by just doing longitudinal traction on the football field. They had no understanding of what the injury was. They just felt like his wrist was dislocated. Interestingly, after that didn't work, they sat on it in a splint over the weekend and referred it to the primary care physician on a Monday. And then the primary care physician referred it to our ER now 4 days from injury. So again, it's a great discussion by Dr. Malone, and you can see that on both views, the gluteus arcs are disrupted there on the AP, and then a lunate dislocation there on the lateral. The reduction was performed in the ER. That was done under sedation because it was a very difficult reduction. But he was neuro intact before and after. And then now the topic is, how are you going to make your plan? What goes into your operative plan? So we're going to talk about that next. So as Dr. Malone alluded to, well, what about closed treatment? Could you treat any of these closed? It's been clearly shown in the literature that operative treatment has better outcomes than closed treatment. But just historically, to go over this, in the past, there was this idea that you could achieve reduction of the scapholunate interval with radial deviation. So you could close the scapholunate gap with radial deviation, but then you had worsened scaphoid flexion. In order to address the scaphoid flexion, you needed ulnar deviation. So there's this paradox that you couldn't get both to get both goals achieved. But what's been the goal of any treatment is to avoid chronic instability and avoid scapholunate advanced collapse wrist and the arthritic changes that come with that. Longer term function is better with open treatment. This is a study, a retrospective review in 1997 by Burgess et al., which they looked at 28 of their patients. They had a non-operative or a closed treatment group and an open treatment group, and followed range of motion, grip strength, pain scores, and return to occupation. And they had uniform poor and a few fair to poor, but mostly poor results in the non-operatively treated group versus the good to excellent in the operatively treated group. But if you're going to treat these, you need to be comfortable with multiple surgical approaches. So let's discuss that. Now, the dorsal approach, it's a midline skin incision, fourth dorsal compartment approach where the extensor tendons are retracted. And then the capsulotomy, the one that I prefer is a ligament sparing capsulotomy as described by Berger, which is this diagram that you can see here. The pattern of the incision is along the fibers of the dorsal intercarpal ligament and the dorsal radiocarpal ligament with the apex over the triquetrum. And then you have a capsular flap that you retract radially, which gives you dorsal access to the capitate, scaphoid, lunate, and triquetrum. And the real advantage of the dorsal approach are to restore carpal alignment, perform your scapholunate interosseous ligament repair, and then of course, the carpal fractures, many of the carpal fractures, for example, scaphoid fracture can be treated from a dorsal approach. The volar approach is an extended volar carpal tunnel approach. And of course, from patients that have acute carpal tunnel syndrome or median nerve symptoms, this gives you decompression of the median nerve through carpal tunnel release. You can access the lunate in a lunate dislocation. And oftentimes the rent and the capsule there can be easily accessed for repair. And then it can also allow access for the lunotriquetral interosseous ligament repair of the volar side. But many of these patients need combined approaches. For example, if they have an unstable lunate that you cannot get reduced, many people would do a volar approach first. Through that rent in the capsule, reduce the lunate, repair the capsule, and then go dorsally to address your ligaments and your carpal alignment. This is a case of Dr. Malone's that he shared with me, and you can see the same principles that we discussed in his talk, that the triangular shape of the lunate, the break and gluteus arcs there in the PA view, and then in the lateral view, you can see that the lunate is dislocated volarly, and now the capitate and scaphoid are sitting in the fossa. This is after reductions. You can see a better alignment. The gluteus arcs are coming back into alignment. And then the great thing about this case, which I didn't have readily available for this talk, was just clinical pictures of that approach. And so this is, again, that same diagram that I showed before. And then this is Dr. Malone's capsulotomy using that same pattern. And then you can see over in the right-hand picture that access to the capitate as well as the scaphoid and the lunate clinically. So what about the your reduction and your plan to address the carpal instability? Well, from the volar approach I just mentioned, this is ideal for adjusting the lunate reduction, the carpal tunnel release, as well as the capsular repair. And then for the dorsal approach, again, it's that forced dorsal compartment, access through the retinaculum, the ligament sparing capsulotomy. You're going to be inspecting the carpus, keeping a record of chondral injuries. That's very important to document that. Oftentimes there's small osteochondral fragments that need to be removed. And then in order to aid in reduction Kwires are placed in the scaphoid and lunate at 45-degree angles away from each other. So you can see that up in the upper left-hand corner here of my slide, that these Kwires as an AO slide are angled away from each other at 45 degrees. And so that allows that when they're brought together, it brings the scaphoid into extension, and it helps reduce the DC deformity of the lunate. But as you think about your reduction of the scapholunate interval, it's going to make it difficult for you to place anchors that eventually will allow you to perform a scapholunate ligament repair. And so that's when I think about, okay, I need to be placing my anchors, identifying where the scapholunate has been avulsed from. Oftentimes it's off the lunate, but it can be off the scaphoid. And then I'll often pass the suture material through the ligaments, although I'm not ready to tie the ligaments before my reduction is done. Those are all have been passed. The reduction is then performed. You can see, in addition to the sagittal correction, we're also in the coronal plane. We're bringing those Kwires together in order to reduce the scapholunate interval and reduce the, reapproximate the scapholunate ligament. And then that's held together with a bone reduction clamp. And then the next step is how we're going to place Kwire fixation. So the reduction and clamping I mentioned, and we're really focusing on the proximal row. So for example, here's a diagram of parallel pins between the scaphoid and the lunate. So those are placed through from the radial side. After the scaphoid lunate reduction has been completed, then I place ulnar Kwires from the triquetrum to the lunate. And then we're ready to complete the ligament repairs. Following this, we want to reduce the midcarpal joints. So we're going to make sure that the capitate is not dorsally subluxated, that the midcarpal joints reduced, and then I place a Kwire between the scaphoid and capitate, as well as between the triquetrum and hamate. I prefer to cut my pins under the skin because of risks of pin tract infection, which can lead to osteomyelitis in the carpus or septic arthritis. You have to be careful about that. Not only cut them under the skin, but cut them short enough that they're not going to erode through. And then most protocols, and the protocol that I follow, is a long arm splint. So yeah, sure.
I'm sorry to interrupt. I just want to reemphasize that point that you just made, particularly any pins inserted from the ulnar column of the carpus, as they're going to be resting in their cast or in their splint, pressure, through gravity, I've as much as I try to bury those pins, leaving just enough out of the carpus so that you can retrieve them later.
Yeah.
I've seen some erode through the skin, and that can, lead to disastrous outcomes.
Yeah.
But I definitely agree with leaving the pins underneath the skin because of the duration of time that we're going to keep them there and the risk of infection. You got to be really careful of making sure they're really short. But
That's a great point. And they're usually fairly swollen. So you can kind of be deceived that you have it short enough, but you don't, because in the next week or so, the hand's going to be less swollen. And so what you think is appropriate actually is going to be maybe too long. But so these are complicated cases. When I think about difficult cases, difficult surgical problems, think of what are your backup plans? Some of these patients are going to require external fixation. If the worst outcomes are in those cases that present delayed, or cases that are open perilunate cases, there may be soft tissue defects. Some of these have gross carpal instability even after you've reduced the global alignment is still unstable, so they may need a dorsal spanning plate or external fixation. Ring's case series was about comparing using a reduction screw. So instead of using Kwires between the scaphoid and lunate, they use a reduction screw. They had less complications with the reduction screw, but of course, that needs to be removed later. But the options for screws include just a standard, for example, like a partially threaded stainless steel cannulated screw or titanium screw. There's also bioabsorbable screws that are available. You want to be prepared for the carpal fractures. And so we mentioned that already about getting advanced imaging instead of making a plan for what type of fixation you're going to do for the carpal fractures, what approach you're going to use. So oftentimes based on the mechanisms of injury, the high energy mechanism, there may not be enough scapholunate ligament to repair. How are you going to augment that? Well, you can use a dorsal capsulodesis, which is thought to using portion of the dorsal radiocarpal ligament to augment the scapholunate repair. And some people describe like making a trough in the lunate if you're repairing it down to the lunate, or a trough in the scaphoid. I was going to ask our panelists tonight, do you ever do that? Do you ever try to roughen up the bone or get back to bleeding bone? I don't think I've ever been aggressive enough to like remove cartilage. So Jeff, what do you do for that?
I do tend to do that more with the LT, because even though I do go volar, I rarely find LT ligament to repair. And as we know that the LT ligament is more important volarly than dorsally. So dorsally, there's almost never anything to repair. So I do tend to include a dorsal capsular, like a dorsal capsulodesis in my closure for the LT.
And when you're repairing scapholunate, as you bring that limb of tissue down, do you make a little trough for that to meet, or do you just sew it to an anchor, or like do you try to augment anything to increase the propensity for it to heal?
Yeah, I mean, if I think that there's good ligament there and it's a relatively acute injury, I'll repair the ligament. But if it's subacute or the tissue is underwhelming, I'll just roughen up a trough and I'll basically create a horizontal mattress suture to bring it down both to the scaphoid and lunate and do it with a capsulodesis.
How about you, Kevin? Any thoughts or ideas about difficulties with the ligament repairs?
I echo many of the thoughts that you've shared. I think that in the acute setting, you can oftentimes see, the footprint from where it came off, and there may be a little bit of cartilage that comes off with it. And then in a more delayed setting, or particularly when you're going to do scapholunate ligament reconstruction, and you're going to use a tendon allograft or something along those lines, then I'm much more inclined to create a formal trough there.
Sure. So the only other thing on this slide to remind me is that oftentimes with the dislocation itself, the dorsal capsule is torn off the dorsal limb of the distal radius. So you may need additional anchors to address that as well. So this is a follow-up of my case. So these are floor images. The top image there is I've placed the anchors, and there was several, put 2 anchors in the scaphoid, but there were also some dorsal capsular avulsions off the lunate that I added some anchors to try to help with the DRC pattern to the triquetrum. And so these are my reduction K-wires. And then this bottom left view is after I've reduced it and placed the pins. I placed 2 pins from Scaphoid to lunate, 2 pins from triquetrum to lunate. And then the mid-carpal wire is from Scaphoid to capitate, another mid-carpal wire from triquetrum to hamate. And then this one was difficult to keep the capitate reduced. So I ended up leaving a transfixion wire between capitate and lunate so that I maintained reduction of that, and the DC was maintained, needed that. So anyways, just to go over those, the order is reduction pins, make sure your anchors are in line, that you passed your sutures, but you haven't repaired things yet. You're going to reduce and pin the proximal row, complete the ligament repairs, reduce and pin the mid-carpal joint, and then finally closure and long arm splint. This is this is additional follow-up for my patient. So this is on the left at 10 weeks before we're ready to remove the K-wires. And so we can see maintenance of alignment and the K-wires are in maintain good alignment. And then this is at 6 months. And you can see that the carpus don't look perfect, but the overall alignment is good. We don't see gapping at the scapholunate interval. We don't see any residual DC, which is something that I'm always concerned about. I'm always concerned, like if I start to see gapping again, or if I start to see the lunate sag into DC. This is the follow-up of Dr. Malone's case. Again, just that dorsal approach by the capsular ligament sparing capsulotomy by Berger, and then the K-wires. And then, I think the K-wires, Dr. Malone, that you use maybe are larger. Maybe if you do a 6'2", you don't need 2 K-wires. What are your thoughts? Do you need 2 K-wires across the scapholunate, or you prefer 1 wire?
I'm not aware of any data that says you need, 2 small ones or 1 big one, and I tend to use the bigger ones. I think that they're less likely to divert from their path as you're inserting them.
Sure.
And they're not taking up as much real estate when you're starting to look for places where your anchors need to go.
That's a great point. And I know that some of the smaller wires, as you're getting them started, they'll kind of, because they're not as stout, that they may take a path that you're not intending. So that's a good point. All right, postoperative protocols. The key here is if the patient has a stiff wrist, but they have excellent digit motion, they're going to still have an excellent outcome, especially if they have a stable carpus and they're not having pain. So early therapy, I think, is incredibly important, especially because they're usually very swollen, and getting digit motion back is so important. But I use a long arm splint for 2 weeks, and then converting them over the next 8 weeks from a long arm cast to a short arm cast. And then finally, the timing of pin removal, I use a minimum of 10 weeks. I see them in the office at 10. By the time they're on my elective schedule to get the pins out, it's going to be past 10 weeks, just depending on what my elective schedule looks like. And then after the pins are out, we're adding the wrist motion protocol. So what about outcomes? Well, this is a multi-center retrospective review by Hertzberg from Journal Hand Surgery Europe in 1993. They had quite a large study. So most of the studies are not this large. This is 166 patients, mean follow-up of 6 years. And some consistent findings were that early treatment was better versus those that presented delayed. Those that had open perilunate and soft tissue injuries had worse outcomes. But 56% of the patients in this series at 6 years had radiographic signs of arthritis. But interestingly, they were still highly functional, had minimal symptoms of their arthritis. Another series by Kreef from 2015 in Journal Hand Surgery. This is a 73 patients retrospective review, mean follow-up much longer at 18 years. And look at their motion. Flexion extension arc was 68% compared to the opposite wrist. Radial deviation, ulnar deviation arc was 67 compared to non-injured wrist. Grip strength was 70%. And they showed similar, even higher rates of radiographic arthritis at 18 years at 70% of their patients. But again, this one included validated outcomes, which the other one didn't. And they followed the Mayo risk score, PRWE, quick dash, and they found that as long as they had good pain scores and maintained this range of motion, their function was high. So in these types of difficult things, I'm always thinking about what are the unsolved issues. Well, one that comes to mind for me is, are there some patients that we should abandon trying to perform a reduction. Should we go on to acute proximal row carpectomy? And this is from David Ring out of Hand and Microsurgery in 2015. And what they looked at are 7 patients, especially if they had a comminuted lunate fracture, if they had a scaphoid fracture and scapholunate interosseous ligament injuries. That's an important thing to remember. Even though they have a scaphoid fracture, still look for the scapholunate injury because you can have both. If they had ongoing or pre-existing osteoarthritis, those are patients they chose to do acute PRC, and they had excellent pain scores, equivalent range of motion, and were able to start early motion versus the pinning. So, but in all of this settings, we really need prospective comparative trials between techniques. Most of these studies have different various injury patterns in the series that they're describing, as well as different surgical techniques. And then one thing that complicates reporting and the outcomes is the severity of the chondral injuries that are so common in these injuries that are not often indicated in the papers. And so that's something to think about, is that even if the radiograph looks good, if there were large chondral injuries, they may still have a bad outcome. So take-home message, preparation is key. Multiple surgical approaches. You need to be comfortable with multiple surgical approaches. Be thinking about your stepwise surgical technique, have backup plans in place. And then long-term wrist stiffness and arthritis are common. And these are my references. I'll turn it over to Dr. Lawton.
Hey, Jay, just
Right.
as a,
Well, thanks, Jay. A couple of questions came up, and just while we're transitioning, and Jay, you mentioned it in your talk, and I'll show some cases of those that had a PRC. But what are your, you mentioned David Ring's thoughts on it. When do you guys think about a PRC for acute perilunates?
I've never done an acute perilunate for this injury pattern, but I certainly have had failures in the older patients that have, like their capacity to heal, like a 75-year-old patient who has some pattern of arthritis already, and their soft tissue ligamentous structures are not very robust. I worry that those are going to fail and go on to PRC. And I've always wondered, should I have considered that as a PRC? But I think his description, Ring's description of a highly comminuted or comminuted lunate fracture, getting good result with that and treating perilunate is going to be difficult. I think that's probably a good indication. I don't know, Kevin, what do you think?
I agree that I've never done an acute PRC for these injuries, but I can, envision situations where you might consider it. And an older person, less physically demanding, maybe perhaps one with pre-existing arthritis or pre-existing, scapholunate instability, where that even this is an acute injury, you're not going to have, soft tissues that you can repair because of the chronicity of their underlying problem that perhaps predisposed them to the dislocation. I have a former partner, now retired, who, had a series of this, but was long ago that it was prior to EMR that we couldn't really ever track down his results or the patient even to look for the results.
Knowing Dr. Keith, I'm sure they did great.
Well, it was Lacey, but yes, I'm sure they did great too. But
so the one thing that I would add is I've had a perilunate in someone who had a connective tissue condition, and that's another one. Someone that you can't anticipate for normal healing of the ligamentous structures that you reconstruct would be another thing to think about.
Sure. Hey, Jay, just before we turn it over to Jeff, you mentioned the volar and dorsal surgical approaches, and sometimes where a combination of volar and dorsal are required. What are your indications for going volar? Is it if as you mentioned, the lunate dislocation and or the median nerve function issues, or are there other times where you would go volar?
I think it's most common for me that when they have acute carpal tunnel syndrome, I'm obviously going to go volar, and it's typical in those lunate dislocations where the lunate's outside in the carpal tunnel. I think that's the most common reason that I do it. The struggle that I have is if we've achieved a good dislocation, or excuse me, a good reduction, and they don't have carpal tunnel symptoms, do I need to do that? Well, one of the advantages of making that decision is that you can close the rent. You can close the volar carpus, or you have better access to the lunotriquetral volar band. But most of the ones that I've done in my career have been dorsal only. and I've been fairly pleased with the results. So I think the most common reasons I do it are when they have carpal tunnel syndrome, and when I'm there, I'm repairing the volar rent.
I think an important point to make is if you do have a irreducible lunate dislocation volarly and you're going to approach it that way, is that oftentimes that traumatic rent needs to be extended. It is almost a finger trap type device behind the lunate. And so extension of that traumatic volar capsular rent at the space of Poirier so that you can open that up, distract the joint, and then reduce it.
Sure. It's a great point.
All right, so now I'm going to go ahead and talk about management of these more subacute or chronic injuries. And these are missed, and we know, from times we've spent rotating in ERs, this is what the ER docs worry about, missing these. Hand surgeons miss these, and as Jay, I think, said in his talk, 25% are missed. So this is a great case, this 28-year-old guy who the night before fell off a ladder, went to a local ER, and came in with this big swollen wrist, but very happy that he was able to see his injury along with the ER doc on his x-ray. And he showed me this little ulnar styloid fracture, and sure enough, it's there. They missed the fact that he had a scaphoid perilunate injury. So we arranged to take him to the OR that night and actually reduce his perilunate. But these are missed commonly. And missed injuries results in delayed treatment. So this is from Chai Mudgall, 47-year-old. Maybe Kevin, if you want to take a look and share your thoughts. This is a 47-year-old who had a fall, and this is a PA X-ray. And I'll show you the lateral, but what do you look at on the PA X-ray when you're describing this to trainees or ER docs or primary care docs? How do you look at that and say, something's not right?
Well, yeah, I mean, something clearly looks not right because you shouldn't see the overlap of the lunate with the other carpal bones. The collulis arc through the mid-carpal joint is disrupted, and the overall shape of the lunate is that triangular shape because you're seeing it in a rotated profile. And
then you would ask for an orthogonal view, and then you would see that. So having said that, you sort of got some thoughts in your mind, but oh, by the way, this happened a few months ago. So now what do you think? Well, I mean, still you made, the diagnosis is right. This is a volar lunate dislocation and now presenting very late. At 11 weeks, I think that there is a reason to consider, trying to reduce this. You're certainly not going to be able to reduce it closed. And I would get, an operative exposure. And if the cartilage looked okay and you were able to get this reduced, I think that going through the repair routine that Jay outlined is certainly a good first step, but I would be very careful with the patient and how you counsel them that this may not be the last surgery that they have, and they may ultimately end up with a salvage procedure. And in fact, that's what Chai did. And so open reduction, ligament repair, and pinning. And again, many of us do this a little bit different, but some variation on the theme in that there's scapholunate pin, LT pin, and mid-carpal pin. Depending on how that looks. And as you can see on the lateral view, restoration of the mid-carpal joint. So again, a nice open reduction on a subacute injury. And then here are the interrupt. You can see, on that last X-ray that Dr. Mudgall left his pins outside the skin, and so it's certainly an option. Yeah, I didn't want to jump into your mutual beneficial society, but I've left them out as well. I sort of went back and forth and did both, and I actually paradoxically found I got more pin problems leaving them sub-Q because, as Jay said, they're swollen and then they come down, and then that pin winds up sort of tenting the skin, and I've had infections both ways. So I've actually gone back to doing exactly what Chai does, which is leave them long and outside the skin and just keep them in a cast. Well, then you don't have to take them back to the operating room to remove them either. Yes. So just different ways to approach it. Yep. There's no right way. So, at 6 months, looks pretty good. little bit of an oblique view, but they often get scapholunate widening, and that's not a crime. But no breakdown of the mid-carpal joint, as you see here. And this fella who did some pretty heavy labor got back to his job. Again, not a perfect arc of motion, but very good arc of motion, as you see here. So there's a few series of these, and many of these are small series that I'll sort of summarize. So this one, 4 patients treated at about 3 months, both palmar and dorsal approaches. And they say, despite the delay, all patients had satisfactory outcomes. There's a lot of descriptors, but not too much objective data on a lot of these studies. So here again, 10 perilunate dislocations, some delayed, some chronic, up to 4 months. They had long-term follow-up, 90-month follow-up. And again, they concluded satisfactory in terms of their results. Here's a series in Journal of Hand Surgery, 15 patients with 16 perilunate dislocations, again, at about 4 months. And what they found is that in their series, the 6 patients that had open reduction in internal fixation versus other salvage techniques did better and didn't require any other surgery. And then a big series by Nash Nam, our recent president of the Hand Association, 19 patients that underwent ORIF of their 24 patients in the series. Mean time from injury was 29 weeks, long-term follow-up. And again, to give our patients an idea of what to expect, we're looking for good results, not great results. Extension average 40%, flexion 50%, and grip strength average 80%. So patients got back to work and did okay, but no one does great after these injuries. So Jay, this is a 20-year-old right-hand dominant young man that I saw, injured his right wrist, fell playing basketball in May, went to student health, x-rays were negative, left the country to do some study abroad, came back 3 months later, and his wrist still bothered him, went back to student health, and then they sent him to see me with these x-rays. So he's 3+ months out from this injury. So what are your thoughts?
Well, at 3 months, I worry that it's going to be very stiff, like it's going to be difficult to reduce the carpus. It may be that area may be filled in scar that you're going to have to release it surgically or with a scalpel to get those things reduced. But I also worry about the longer time period. Like, would there be sufficient? What would the health of the remaining like scapholunate ligament limb, the lunotriquetral ligament? I just worry about the health of those, like if they're stout enough to be repaired. But I think it worked in a 20-year-old. I would try to get it reduced. I just worry that it's going to be a stiff deformity. And this looks like a Mayfield 3, I think. Like it's not all the way. It's definitely not a dislocated lunate. It's still a very
yeah, it's a perilunate sort of perched. So yeah. I agree. And this was in the day before we had other augments. So one of the questions is, what is the role for an internal brace, perhaps? So this is his motion before surgery. So again, pretty darn stiff. I did an open reduction. In this case, ligament repair supplemented with capsulodesis. Again, in this day and age, might have supplemented it with some internal brace type material. But
would you ever
did an open reduction?
Yeah, would you ever consider like some type of FCR graft, like just going straight to like a recon?
Yeah, so I have another case that I'll show where I did that. This was soon enough out, meaning only like 3.5, 4 months that I didn't. But yes, I have done that. I'll show a case of that. So again, here he is, 4 months out, had some scapholunate widening. Quite honestly, I wasn't able to actually reduce all that even in the OR. Yeah. So I can't even blame it on recurrence after taking the pins out. Yeah. I couldn't get that closed down, at 3.5 or 4 months. And I saw him at 4 months from surgery, and that was the last follow-up. But again, at this point, his mid-carpal joint is reduced, and it's been about 10 years, so I haven't seen him back. So
you think about the concepts of carpal instability, because it can be dynamic, static, or fixed. And this would be one, like as it goes on, time goes on, it just becomes scarred in that area. And so the idea of getting it reduced is going to be very difficult.
Yes. So this is one that I'm still not sure of. So this is a 17-year-old young lady that came to see me about 6 months out from her injury. So here's her injury films. And she was taken care of by an orthopedic surgeon who identified her radial styloid fracture and pinned her radial styloid fracture. And then she had a stiff, painful wrist. 6 months later, wrist still on a pillow. Her arc of motion was from 50 degrees of flexion to 10 degrees of flexion. Jay, what do you think of the films here? I mean, it's a little bit subtle, and think back maybe to Kevin's Mayfield stage. I mean, I thought there was some version of a perilunate. I don't know if I'm making myself believe it, but I could sort of imagine a stage 2. You could see her lunate is, 45 degrees to the long axis.
That almost has like a mid-carpal, the perilunate, maybe like the stage 2, because she's got scapholunate and the mid-carpal's affected. And now she's developing the VC versus the DC.
Yeah, so that's the best I could reason. I mean, I wasn't 100% sure what I was looking at, but again, given that she's 17, I certainly gave it a go to open reduction. I didn't think that PRC in a 17-year-old was a great option, and I didn't think she was going to get any more motion with therapy. So 6+ months out, dug out a lot of scar. And then you asked the question about, like some version of a Brunelli, and that's exactly what I did. So I did an open reduction, and once I was sure that I could actually get the bones in alignment with my joysticks, that's exactly what I did. I took half her FCR, came through the scaphoid, and then went across to the lunate with an internal brace and anchor, and then went to the lunate. And then pinned everything. And then despite that, here she is at 10 weeks status post ORIF. And I mean, I may have not got my pins in the lunate ideally. In other words, the pins are in the volar third of the lunate, and ideally I'd like them in the middle of the lunate. But, now she's recurred, so the same problem, or almost the same problem that she came with, she's got again.
And I wonder, like, even if you use like a radial lunate pin to try to hold it in a good position, as soon as you take that pin out, because it was scarred down in that original position, I would predict that it's likely going to try to return back to that position.
Yeah. So I talked with her about, revising it and doing something like that. They wanted to just sort of watch it. So we got her moving, and she's now got a 90-degree arc of motion and no pain, and she thinks it's great. I'm not convinced that that's the last thing her wrist is going to need, but
don't take any more x-rays.
Well, and that's exactly what I told my PA. I was like, well, I don't need to see any more after seeing that x-ray. I don't need to see any more. And we'll treat her clinically. Agreed.
Yeah.
Did you get an x-ray of her other wrist?
I did initially, and her lunate is, pointed
Normal.
straight ahead, not pointed down towards her palm. So this is a case of John Capos, 23-year-old, went out of a second-story window, injuring his left wrist. And so this is a spilled teacup, and then the teacup got turned over on itself. So the well-intentioned hand surgeon that night did his best to sort of open it up and put some pins in, and has some pins crossing that scaphoid fracture. And then John Capo saw this about 5 weeks post-surgery. So Kevin, if you've got this now a month and a half old, what are your thoughts?
Well, it's interesting x-ray because, you have the pins from I guess those are the scaphoid pins volarly. So coming right near the radial artery and median nerve and flexor tendons, all those type of things. I mean, I think that, the pins need to come out. You have to open this up dorsally, and, see if, cartilage is good, scaphoid is viable, reducible, and start over again. Fortunately, with them being Kwires of different calibers, there's not a lot of bone that has been disrupted. And so, there should be good space there to put new pins, a screw for the scaphoid, anchors, etc.
Yeah, and he's 23, so you're gonna, certainly give it a good hard try, and hope you can get it back. So, agreed. I mean, I think it makes all the sense in the world to take him back. So John had some clinical images that he sent as he was sort of doing what you said, take it all apart, piece it back together, get your reduction. He used some Kwires as joysticks. And then he did something that I'm not familiar with, which was he did not just radiolunate pinning, but radiolunate capitate pinning to maintain the midcarpal joint. And Jay sort of made that comment for mine, possibly pinning the midcarpal joint, and then pinned the radioscaphoid joint, and then supported everything with an X-fix, as you see here. And then 6 weeks post-op, X-fix, and the pins were removed. And then that actually had represented in many patients, many perilunate and lunate dislocation patients. We often don't see them in follow-up, but John actually did see him 5 years out, and he was having some mild pain. But John talked with him about another surgery, and no secondary surgery or tertiary surgery is yet scheduled. So sort of the natural history of that, and that was the end of follow-up. So Jay, this is a 28-year-old young lady, injured her left wrist in an MVA. And again, I'll give you the lateral X-ray, but what are your thoughts on this PA X-ray?
Well, I'm trying to find gallulas arcs, which are disrupted, but also just the global axis of the carpus is translated ulnarly. So it makes me think of a greater soft tissue injury just to the wrist capsule and the wrist ligaments as well.
Yeah, and one of the questions was, and this is one of the things that I struggled with on this case is, one of the audience members asked the question. We talked about doing an acute PRC for a perilunate, and remember, in a PRC, what you're worried about is the radioscaphocapitate ligament. Yeah. And this patient, you certainly worry about that, because I agree, it's more than just the lunate out of place. It seems like the carpus could be out of place as well. And that's something I worry about with doing a proximal row carpectomy. And again, you see her lunate dislocation, and because my talk is not acute injuries, so she was 3+ months out. She was a multiple pack-a-day smoker, amongst other things. I didn't think she was a great candidate for open reduction with repair/reconstruction. Her biggest problem, though, was not her X-rays. It was what she described as this painful bump. So this is her wrist. Her hand is to the right, and that bump right in the middle was very painful. And here's an explanation of why. So Freer is pointing, this is her median nerve. You can see sort of strewn out over her lunate. So she had median nerve symptoms and ulnar nerve symptoms. So I did the extended carpal tunnel, as was mentioned, for the volar approach, and did a PRC. And in the operating room, I was prepared to span her if her capitate didn't sit down in her lunate facet, but it did. So I just did a PRC, and here she is a few months post-op. Pretty good motion, and I've actually seen her back 5 or 6 years for other things, and she's still doing well with this. So
I'm curious, Jeff, about the volar capsule for her. Was there, at 3+ months, was there anything there that you could repair, or was it already healed or closed? Or
yeah, it was healed. There wasn't the rent that you normally see with an acute perilunate. I was able to see it because I just sort of CSI hand surgery. I sort of was curious, the space of Poiré, and you could, there was some scar tissue there, but you could easily get through it like with a freer or tenotomy scissors. In other words, it looked like there was fascia there, but it wasn't like robust capsular tissue.
Yep.
I was more curious, sort of the path that the lunate came through.
Yeah.
So it had healed ish at 4+ months.
Yeah.
So, what's the role? Lindley Wall and Peter Stern did a review of proximal carpectomy, and one of their indications was chronic perilunates. There's a series looking at 12 patients, 15 weeks out, where they did volar dorsal approaches, median nerve decompressions, and at almost 4 years, I love this description, an effective wrist range of motion and grip strength were restored, which again, a modest result from a terrible injury is a good result, I think. So remember, when we're talking about salvage, remember about mid-carpal fusions as well. Kevin, I'm happy to let you present your case, but this is your 25-year-old right-hand dominant man that you sort of did everything right, in that you reduced them, you reconstructed them acutely, real nice construct, and then you thought this was going to be a home run, I'm sure. And then what's they say, nothing ruins results like long-term follow-up. So at 6 weeks, he looks great. At a year and a half, 15 months, having some symptoms. And was there a thought of anything else at this point, or just sort of let it ride?
Not at this point. I think we were just, let it ride. He was a little stiff. He was working. Clearly his mid-carpal joint is very narrow, and this particular patient did have a large chondral defect off the head of his capitate, so I wasn't overly surprised that his mid-carpal joint narrowed down.
And then, he kept narrowing, having more pain, but, now he's a couple years out, 3.5 years out, and he said enough is enough, and you did a mid-carpal fusion. Yep.
Not an easy fusion to do, and they're that stiff too.
Yeah.
I've always thought about that for these salvage procedures, because they'll be stiff. They'll have a stiff DC. Some of them will. It's difficult to get the capitolunate axis reduced, and then if you don't, they'll impinge dorsally. Like you'd like to not fuse them in DC. You'd like to get that reduced. Do you guys have any tricks on how to get them out of DC if they're very stiff?
I think it's a wide capsular release, and not only is it hard to sometimes get them out of DC, but to get the wrist flexed enough if you're going to use a technique like this with these compression screws from the lunate into the radius. And I've unfortunately experienced situations where I have fragmented the lunate in trying to do that, and then had to convert to a capsule interposition or a total wrist fusion.
It's hard to get it out of DC, and it's hard to get the lunate radially translated enough. In other words, to get it back under the capitate, it wants to scoot ulnarly, as you can sort of see here. Yeah, it's tough, and especially this one was 3.5 years later. So I did want to weigh in. We've talked a little bit about the volar dorsal controversy. So this was this young man that I showed you that proudly came in telling me where his ulnar styloid fracture was. But this was his volar approach. So this is his hand here. This Army Navy is holding the carpal tunnel contents median nerve. And here you sort of see, I sort of describe it as a upside down smiley face or a frowny face. It sort of goes all the way over, and it's this big semilunar arc injury here. And here you see it sort of wide open and gaping. And then you can put a series of permanent sutures in it, with careful retraction of the median nerve. I tend to go volar and dorsal for almost all of them. I agree with Jay. Most of the work you're going to do dorsally. I've just always thought that repairing this capsular rent was important. That's sort of my training, and that's what I've always done. But there's different ways to do it. So You know, I think you've heard from all of our talks that perilunate injuries are bad. Having one that's chronic or subacute is probably not better. You know, very important to ask and decompress the median nerve, and then some form of salvage, be it PRC or midcarpal fusion versus ORIF. Still, in these devastating late injuries, can result in a good outcome, not a great outcome. So thank you.
Thanks, Jeff, and thanks, Jay. I mean, I think, you know, we've presented a number of different injury mechanisms and timing of presentation, and hopefully we've provided a framework or a strategy for which you to, as the participants, to address patients that you may see with these injuries as they come into your practice. You know, I don't see any unanswered questions, and unless anyone has any other comments they want to make, we can.
There was one question that I sort of alluded to. I didn't get either of your comments on. Now, what do you guys think is the role, or is there a role for internal bracing, supplementation beyond repairing ligaments, dorsal capsulodesis? Do you think that the ability to perform an internal brace allows us to do some things with that, apply it to these injuries?
I think an internal brace to augment your repair in situations where the ligament tissue is not great is certainly an option. I mean, those are big holes that you have to put in the scaphoid, the lunate, and wherever else you're going to anchor that internal brace. You know, there was a question about acute ligament reconstruction, and I think I would shy away from doing that at the same time as you know, reducing and fixing a fracture dislocation. And if you know, that needed to be done at a later stage, if the cartilage was still good, you could do that in a staged fashion, but you sort of run out of real estate when you're going to start passing tendon grafts through bones, or even the you know, the 3-5 anchors that you're going to put in with an internal brace. Yeah. You know, Jay mentioned other tissue that you can use: the dorsal intercarpal ligament, you know, the black capsulodesis, the dorsal radiocarpal ligament. There are other tissues there. And just as you know, one of the things that I do is after I place my anchors, you know, in the scaphoid or in the lunate, wherever it has avulsed from, I don't cut those tails, because after I repair my capsule, I bring those tails up through the capsule and then tie them over a dorsal capsular bridge as well, because we know that there is a dorsal capsular attachment to the scapholunate ligament, and so just trying to stabilize it that way as well.
Well, years ago, I saw at the Hand Society someone describe using larger suture calibers for these, whereas in the past I might use a 4.0 type of non-absorbable suture, and they were using 2.0, which kind of surprised me. Like, that seemed kind of large, but it kind of makes sense. They're using things that are they're trying to lessen that attenuation and stretching out over time and offloading that. So I've kind of tried to do that, but without kind of mixed success, I guess I would say.
I think with a bigger suture, you have bigger needles, and that stuff doesn't pass as well through that, you know, torn, shredded
Sure.
ligament as well.
Sure.
Well, great. Thank you so much, Jay and Jeff. And again, at the end of this session, you guys will receive a link to a questionnaire. And after you've completed the questionnaire, then you'll be given information on how to claim and receive credit for CME. Have a good evening, and thanks again on behalf of AO North America.